Well, good afternoon, everybody. Thank you so much for coming to today's Data to Drive Decisions webinar hosted by Civic. Today's topic is Better Through Benchmarking. We're going to be talking about local and national data to help communities improve health and lower cost. Just a few housekeeping items here. All lines are muted today. Please ask questions in the chat box. We will take questions as mostly at the end, but if there is anything that comes up in between that we need to clarify, I will take those in the middle. So feel free to chat at any time. We are recording this webinar, so it'll be available with the slides and a link to the recording on our events resources page at civic.org. I'm super excited today to be joined by some great presenters. We have Doug McCarthy, who's Senior Research Advisor at the Commonwealth Fund, Awana Krasan, who's a data scientist that we work with at Human Services Research Institute, and they are our data warehouse manager for the Colorado All-Payer Claims Database. I'm also joined by my colleague, Maria de Jesus Diaz-Perez. She's the Director of Research and Performance here at Civic. And my name is Carrie Frank. I'm the Vice President of Communication and Marketing and manage the public reporting here at Civic. So quick agenda, we're going to talk just briefly about Civic and the APCD in case you're joining for the first time and are unfamiliar with who we are. Doug McCarthy will be sharing Colorado results of the Commonwealth Scorecard on state healthcare performance. And then we'll go over a brand new community dashboard that is not yet unveiled. So for the first time, some of you will be seeing the new measures and new functionality of the community dashboard that will be going live fairly soon here in Colorado. We'll share some initial results and insights that we're seeing in the data, and then we'll do some Q&A at the end. Just quickly about Civic, our mission is really to empower those of you on the ground who have the boots on the ground, communities, organizations, and support the work that you're doing to advance the triple aim of better health, better care, and lower costs. We're a nonprofit organization. We pride ourselves on being independent and objective. We serve a wide variety of stakeholders that do touch healthcare. Everyone who is focused on healthcare also has the consumer in the middle, and that patient is really ultimately our goal is to make Coloradans healthier and improve the care and lower the cost for the consumer. We do our work in a variety of ways. So when we're focusing on just the data that we provide, the all-payer claims database data either comes out publicly, which is what a lot of what we're talking about today, and then we also offer custom analyses as well. And in case you're unfamiliar with the all-payer claims database, we do have payers across the commercial space. We have Medicaid, Medicare, and Medicare Advantage, and we'll be showing you a lot of data broken down by those payers. We have close to now 800 million claims in the database. It represents a vast majority of the people in Colorado, certainly those who are insured. And I'm going to go ahead and turn it over. So we've structured this today to look at first at a high level, like how is Colorado doing in general compared to the rest of the nation? I'll turn that over to Doug here in just a second, and then we'll break it down on, even though Colorado, when you look at it as a whole, you can see results. It's really interesting to start digging down deeper into Colorado and the different communities in Colorado and counties in Colorado. So we'll do that next. So first, though, I will go ahead and turn it over to Doug. Thank you so much. I have to mention too, Doug is our board chair and he is fantastic. And so we appreciate him on a number of levels, but we're really excited to have you here with us today to share what you guys have learned at the Commonwealth Fund. So go ahead, Doug.
Thank you, Carrie. It's my pleasure. And I can say I'm very excited about this opportunity to pair our scorecard with Civic's community dashboard, because when we present the scorecard, we always get the question about what it looks like within my state. And now Civic has performed that for Colorado, and so it's really very welcome, and I hope other states will learn from what you have done as well. I want to mention before I start that I have been involved with the scorecard for many years. I currently am no longer directing that team, and I want to acknowledge the authors of the report this time that were responsible for producing this scorecard, and that was David Radley, Sarah Collins, and Jesse Baumgartner at the Commonwealth Fund. And as always, the views expressed are my own and not those of the fund. Scorecard's purpose is really very simple, and that's to provide benchmarks and trends to inform action to improve healthcare system performance across the country. It's done at the state level because that's the nexus for a lot of policy decisions and collaboration. The scorecard uses 49 indicators that are drawn from a variety of data sources, including claims data, surveys, and vital statistics. And we look at data over a 2 to 3 year trend. At the time it was published last year, it was the most recently available. We're preparing to do an update quite soon. The scorecard is ranked using standardized Z-scores, and we have a very simple methodology of simply ranking the indicator scores to come up with dimension scores. On the right, you'll see those 4 dimensions that we measure, as well as equity at the center across all those dimensions. And then we average those indicator rankings, or those dimension rankings, rather, to get an overall score. And I'll be focusing today on a subset of the indicators that are congruent with those in the community dashboard. So great news for Colorado. We have moved up over the course of the scorecard, which we started in 2011 when we were in the middle of the pack. We are now at the top. We were in the last scorecard in the top quartile, and you can see here we moved up 4 rankings, and now we're number 6 overall and number 1 in the Rocky Mountain states. The best dimensions: prevention, treatment, avoidable use, and cost, and healthy lives, where we are almost in the top 5, or in the top 5 for 1. We do less well relative to other states on access, affordability, and we have room for improvement in disparities, which in this scorecard are focused on income. We'll be producing an equity scorecard in November, which will be looking at racial and ethnic disparities in more detail. On the right-hand side, you'll see the donut, the good news there. In the blue, we're improving on more indicators than we're worsening in the orange. Next slide. So this slide shows you those indicators where we are ranked at the top. And as you might expect, those are in healthy lives. And I think it's great that we also have a hospital system that is providing very patient-centered care according to the rankings, and we're doing a good job at preventing those hospitalizations. If we do less well, you can see at the bottom, we are less able to rise to the top on one indicator of access, which I think is interesting. That's usual source of care, because maybe we're healthier and we don't think we need to have a regular doctor. And then we'll talk more later about the deaths of despair. Where we've improved the most, I think, is very promising on mental health indicators. So we've taken to heart some of the lessons that the state has learned and efforts that have been made. We still have more room to improve, but that's very promising. And we'll see what happens with vaccinations after COVID. Next slide. So on this slide, we show some of the indicators in prevention and treatment, or you might think of these as quality. And I've circled in orange those that are congruent with the Civic Community Dashboard. We do somewhat in the middling in terms of our relative ranking for adult preventive care, cancer screenings, and one indicator of chronic disease management, whether you're getting your annual blood test if you have diabetes. We do better for children for well visits, which you'll see on the dashboard. And as I said earlier, we're doing better on children's mental health as well. Next slide. And I should say, by the way, all these indicators are an average, and there are people who have less good experience. Colorado does very well on measures of avoidable hospital use. This may reflect both a more efficient healthcare system, better prevention, but it also may reflect a healthier population. These are population-based rates. We still have some room for improvement in emergency room use. Next slide. But what's surprising is that we don't do as well as you might expect on overall cost of care, and especially for commercial premiums, where we rank higher than you might expect. Next slide. And the reason for that is because of what we see here. This slide shows you the relationship between overall premiums for employer coverage on the left, and on the bottom, commercial prices paid for those services. Now, the variable here is utilization. So the states that are above or below the line, utilization is playing a greater role. But in Colorado, we're right on the line in the upper right quadrant, where we have higher costs and higher premiums. And that's something that, of course, our state is very interested in tackling. Next slide. As I mentioned earlier, deaths from despair, from suicide, alcohol, and drug overdose are an area that our state stands out in a bad way. And it's interesting in these maps because you can see that it's actually a regional pattern that we are a part of. And so perhaps there's opportunity for regional initiatives to tackle some of these issues that affect our state. Next slide. I appreciate your following along with me very quickly. This is a measure of disparities by race and ethnicity. And Colorado has rates of premature deaths for blacks that are twice as high and 21% higher for Hispanics than white Coloradans. And interestingly enough, you'll see for Colorado, the orange dot is above the green dot. We are one of only 3 states, the others being Hawaii and I'm sorry, I just forgotten the other state, and Connecticut, sorry, that have higher rates of Hispanic deaths from treatable conditions than whites. And that might be an area for investigation. Next slide. We wrap all this up into some indicators of improvement where this is kind of to motivate us, right? How much benefit could we gain by working on those areas where we still have gaps? And across states, even high-ranked states all have areas for improvement, and low-ranked states have particular areas where they stand out. So we can all learn from one another. We can see these kinds of thousands of lives that would be impacted by better preventive care, better access to care, and keeping people out of the hospital. And in the end, we can see more or fewer premature deaths, people living longer because of that. We hope that you will want to dig down into the data. We have a new, next slide, we have a new health system data center where we're continually updating the indicators, even beyond those that are presented and scored in the actual scorecard, so you can keep up to date at this address at the bottom. And we hope you'll share with us any thoughts you have for improvement. Thanks so much.
Thank you so much, Doug. That's terrific. And like I said, if you have questions for Doug, please put that in the chat. We'll take those at the end. But that was a lot of information very quickly, but that sets us up really nicely at a high level to talk about what the next topic, which is the community dashboard updates that we have been in the process of making now for several months, actually, probably before the beginning of this year. We started planning for it at Civic and working with our data partners, HSRI, who you're going to hear from here in just a second. And I do have to thank a lot of our community across the state for helping us determine some of the new measures that you're going to be seeing today. Every year we have an opportunity to decide what is going to go into this dashboard and what those measures of interest are across Colorado. So thank you to our advisory committee and to the board and to our data release review committee and anybody who gave us input on that. So I will jump out and we're gonna demo the dashboard because I think the best way to hear about it is actually to see it, at least for me, since I'm a visual learner, and maybe that's you out in the audience as well. Just a note of where you're going to find this. So this is not currently available in the way that we're going to demo for you today, but the original or the one that is available now is on our website here. You get to it by Get Data, going to Public Data, Focus Areas, and then it is a drop down of one of our focus areas, Community Dashboard. That's going to be where this lives. What you see on our website currently is not the one we will show you today, but that's where it's going to be once we release it. So I do have the new page here that we're going to show today. And it's going to be set up very similarly to a lot of our other interactive reports where we have kind of just an overview of what this is. Consideration section is always something to take note of. We don't have everything in the all payer claims database, and there are some just little caveats that you need to be aware of while you're looking at this information that this can be a helpful section for you. And what we like to do is look at some of the insights and kind of list those up front because it's a lot of information to take in. We always have a methodology. So if you are interested in any of these measures in detail and how we have calculated that, you can click on that more information about the lives in Colorado by county, because not every county has the same percentage of coverage that we get in the all-payer claims database, depending on if there's more self-insured or maybe there's more VA or other payers that we aren't getting. And then we do have the ability to click on this link, fill out a form, and get all of the information downloaded, which Awana will tell you more about here in a second. So this broken down into insights by pediatric data insights, which we're excited to have for the first time in this release, and then new quality utilization and access insights. And then we also have a nice infographic summary. You're going to see some of this. Marie's going to talk to you about what are we seeing out of this data if you don't want to go through and kind of dig into it yourself. But you do have the ability to dig into it yourself. So I am actually going to turn it over to Awana. She's going to talk to you about the new functionality that we have here in this new dashboard. So Awana, please join us.
Thank you, Carrie. We are very excited to introduce to you the new content and the new features available in this 2021 dashboard. And our teams, as Carrie mentioned, worked together over the course of the past year to add new measures and new displays of the data. And I'm going to walk over mostly the displays and the navigation that is newly improved in this iteration. So right now we start from an overview or definitions page. This introduces all the available measures on the dashboard. We are looking at the list now. The report also has a regional and county profiles tab where all available measures are displayed for a single geography. The remaining tabs, and those are cost, quality, utilization, access tabs, they present a subset of the measures and they display a single measure at a time for a selected geography and then showing a map for the entire state. So as I mentioned on this overview page, you will have information not only on the complete list of measures that are presented in the report, but also their definitions. So for example, if we look at the first, which is the health plan and patient total cost of care per person per year, the definition indicates that this is the risk-adjusted calculation. It combines the patient cost and the plan cost, and it also encompasses all the subcomponents of the cost, so inpatient, outpatient, professional, and pharmacy. Now, moving on to the profile tab, here you can view a summary of all the cost, quality, utilization, and access to care measures. And those are available for the selected county or region, all in one place. Here and throughout this report, measure values for a specific geography are put next to the statewide, urban, and rural benchmarks. The report includes an instructions button, and that provides more information on how to use the display. You would just click on it, and each tab provides additional instructions. Now, in this profile view, each of the measures has a symbol attached to it, as you can see, and this indicates how the county or region is faring when compared to the statewide value. So it's a comparison against the statewide column only. And the symbol indicates two aspects. First of all, the direction of the arrow shows whether the county or region value represents a higher or lower value than the statewide by pointing up or down respectively. When the arrow is absent, it indicates that the region or county value is the same as the state value. Then the color of the symbol indicates whether the difference between the county and the state is a better or worse outcome. So green means a better outcome than statewide, orange means worse, blue indicates same value as the state value. So for example, if we were to look at the first row, which shows, once again, the health plan and patient total per person per year, and this is for Adams County for 2020, and the commercial population, we can see that this county fares better than the statewide. We have a lower total cost per person per year value than statewide. And also in this display, you can view how the county or region is performing when compared to all urban counties or all rural counties. And those are labeled urban and rural in this display and throughout the dashboard actually. Or you can compare how the, all rural or all urban compare with statewide. So for example, in 2020, we can see that the rural counties have a higher total cost per person per year than urban counties. On the left side, there's a set of 4 filters, and they allow you to select data for either, first of all, for a region, DOI region, Department of Insurance region, that is, or a county. Pick the geography of interest and then choose either the most recent available year, which is 2020, or a previous time frame, which goes back as far as 2013. We display data by major payer types, that is commercial, Medicaid, Medicare Advantage, and Medicare fee-for-service, and also an overall value for all payers. The default selections are, in all views throughout this report, commercial, 2020, and Adams County. And these breakdowns, so year, geography, payer type, are standard for all displays of data in this report. You will note as you navigate this that some payer types are not applicable for all measures. So for example, the well-child visits measures will not have data, of course, for Medicare fee-for-service. And so the dashboard will display NA for these measures if Medicare fee-for-service is selected. And relatedly, Medicare fee-for-service data were not available for the complete 2020 calendar year at the time of the report production. So these data points are not present in the report. They will also be displayed as NA. And it also impacts the availability of 2020 data points for all payers, though that is only for the measures for that are computed for a Medicare fee-for-service population alongside other payer types. Lastly, we have ensured that values that are created based on fewer than 11 data points for a particular breakdown combination are suppressed for protection of privacy, and those will also be displayed as NA. Now, moving on to the cost of care view. This tab has 2 displays embedded in it. On the default or landing display, you can select one of the cost measures from the drop-down menu, and then you can filter the data using the breakdowns on the left side. So geography, year, and payer type. The top bar chart will allow you to easily compare the cost per person per year, risk adjusted, with the statewide, urban counties, rural county values. And as a side note, as part of this report, data users that are interested can be provided access to the underlying data in Excel format, as Carrie mentioned, and the respective Excel files for some measures, but not all, will include additional statistics then and additional demographic breakdowns then are included in this dashboard view. So for example, for cost measures, users could also access the raw non-risk adjusted calculations in addition to the risk adjusted calculations you see on the screen now. And while the dashboard will always display the measure for the overall population that the measure was computed for. So in the case of cost measures, we have all genders, all age groups. The Excel files include detailed age group and gender breakdowns. So specifically for cost measures, you would also be able to view 0 to 17, 18, 34, 35 to 64, and 65 or older by gender. So these supplemental age and gender breakdowns are available depending on the measure standards. So for example, access to care for adults will have a different set of age group breakdowns than for cost of care. Then the map below displays a county level view of this measure. since we have county as the geography selected for this display. Highest cost values are in dark orange. Lower cost values are in dark green. So for cost measures, lower values are better. And we can easily see that cost per person per year tends to be higher in the northwestern, western, and northeastern part of the state. Maps provide additional statistics in the tooltip view. So when hovering over a particular county, you're able to see the value selected for the year and also for the previous year, as well as a calculation of the change between the two. So for example, Kit Carson has 11.6 percentage decrease from previous year in the cost per person per year. And we're looking at commercial population here. Moving on to the second display of the cost measures, which you can do by clicking on the right arrow button on this display. We have the same measures, but they are displayed as a cumulative bar chart. So in this display, you will be able to easily compare the portions of the overall cost per person per year that represent inpatient, outpatient, professional, and pharmacy costs. And alongside, you are able to compare health plan only with patient only cost. You can come back to the first display of the cost measures by clicking on the left arrow button. Now, the quality of care and utilization access to care tabs are similar to the first display we looked at for cost measures, in that we can explore individual measures with a bar chart that highlights the selected geography, and then below with a map of the state. So now looking at the quality of care measures, first you can select a measure from the drop-down menu on top, and then find the breakdowns of interest using the filters on the left side. So let's pick diabetes, HbA1c testing, and keep the default Adams County, population with commercial insurance, and 2020. We can see that actually for this measure and all measures on this quality of care tab, higher values are better. So the color shading on the map is calibrated to show better outcomes in green, so higher values, and worse outcomes in orange. Those are lower values. So here the map points to some regional patterns once again, where Southwest and some of the South and some of the East counties are faring worse than the rest of the state. Note that some counties have gray shading. This happens either because no data was available, or most likely in the case of this measure, the statistic was suppressed due to low volume. Lastly, we have included healthcare utilization and access to care measures on the rightmost tab of the dashboard. One aspect that is important to point out, and particular to this tab, is that it shows a combination of measures where a lower value represents a better outcome, and measures where a higher value represents a better outcome. But for all the measures in this view, orange shading on the map represents lower values. And to differentiate between the two types of measures, which will help with the interpretation of the map, please pay attention to whether there's an asterisk displayed next to the measure in the drop-down menu. Measures that have the asterisk indicate that lower rates are better. So for the measures that have an asterisk, orange on the map represents a better outcome than green shading. Let's give this a moment to load. And we're going to take a look at an example that shows this type of measure where orange shading on the map represents a better outcome. So let's take a look at the rate per 1,000 members for the emergency department visits. Let's select DOI regions as the geography type.
Apologies. Of course, when you get on a webinar, it decides it wants to spin. Yesterday, when we were looking at it, it was going very quickly. In DOI region here.
We'll leave it as 2020, and then let's select Medicaid insurance and Denver County.
Okay.
Sorry, Denver DOI region.
Anyone in Medicaid?
Yes, please. Thank you. So once we selected Denver, that is the region that is highlighted in the bar chart. We can see that for Medicaid 2020, the Denver DOI region is faring worse than the state average, meaning the statewide value. So that's because the rate, 560 per 1,000 members, is higher than the statewide rate, 537 per 1,000 members. And for this measure, lower values are better. The map below indicates that the western regions of the state and the Boulder region have better outcomes than the rest. And to recap, that's because orange shading on this in this view always indicates lower values, and lower values for this measure represent better outcomes. So if we hover over the Denver region on the map, based on the information displayed in the tooltip, we can see that the rate has decreased by approximately 21% when compared to 2019, which is a positive change. And one feature we would like to mention, if you would like to save a snapshot of the view, either on this tab or all the other data tabs, you can use the download button in the top right corner. And when you click, this will either automatically download a PNG image file or will walk you through the steps through the menu. So as I said, this feature is available on all the report tabs that display data. So we invite you to explore these measures in more detail. And as Carrie mentioned, if you like more information about methodology, the web page where this dashboard is embedded will provide a link to the methodological notes. And for any additional questions you may have, please don't hesitate to reach out to us. Thank you.
Thank you so much, Awana. I appreciate you walking through that. And sorry for the delays we were experiencing. I am now going to turn it over to my colleague, Maria, who has been digging into the data to say, what is going on? What are we seeing? And that's the exciting part, I think, about our jobs here at Civic, is we get to see this information for the first time and figure out, are we doing good? Are we doing bad? Where do we have those opportunities? So Maria, go ahead.
Thank you, Carrie, and thank you, Joanna. Thank you all who joined us today. It is my pleasure to be here sharing with you a little bit, just a little bit of the community dashboard. As you saw through Joanna's demonstration, this has tons of information. So I'm just going to highlight a few of the new measures that we have in this community dashboard. And of course, when it is released, I invite you to explore and to look at all the measures. But I'm going to start by highlighting some of the measures because we are, as Carrie mentioned, very pleased that we were able to add some pediatric measures that we didn't have before, and they are very important to evaluate quality of care and access to care. And the first measures that I'm going to highlight here is the well-child visits. And for those of you out there, well-child visits are very important because it's the opportunity that providers have to conduct the screenings to assess the developmental well-being of children, the physical, psychological, social, and behavioral well-being, and make sure that children are developed, are set in the right path, and they can develop healthily. And as you can see, these two measures are trending in the right direction when we look at the data from 2013 to 2019. And there are two measures featured here. The first one is the receiving well child visits for infants, that would be babies up to 15 months. And according to national guidelines, this group of age requires to receive 6 or more visits in this period of time. And those visits increased in 34% from 2013 to 2019. And in the case of the following group, the well child visits is the group of young children, and they need to receive 2 or more visits in a given year, 2 or more well child visits. And as you can see, we also see an increase. It doesn't seem as pronounced as the other, but the thing is that the 15-month needed much more improvement than the older group. So the 15-month is ending in the high 60s, and the 16-month is ending in the high 70s. So there was much more room for improvement in the young children. We have a third measure of well child that is not shown in the graphic, but it's for adolescents 12 to 21-year-old. And that is a very important measure because, as you can imagine, at that age group, the rate of well child visits drops considerably, but it is still a very important visit. This is still a very important visit to set our adolescents right for the change in life. And you know, they need HPV vaccinations, and they need chlamydia screenings, and they need also potentially preconception counseling, and those are great opportunities to provide those type of services. Next, please. The other two new measures that we are going to highlight here are grouped in the utilization tab that Joanna showed to you. And we are calling them hospital utilization measures. They are the ambulatory sensitive conditions and 30-day hospital readmissions. But even when we are showing them in the hospital utilization measures, they are considered, they can be used as quality measures. And I'm going to tell you a little bit more why. The measure on the left, the potentially preventable hospital visits, if you remember, Doug mentioned that as a whole for Colorado, that we currently are doing well, or we tend to do well in that measure. That measure is an adaptation of a very commonly used measure developed by the Agency for Healthcare and Quality and Research and Quality, ARC. And the measure is a representation, is a rate per 100,000, and it's a representation of hospital discharges for chronic conditions and these hospitalizations could have been avoided if chronic conditions had been treated in high quality outpatient settings. So I'm going to say it again because I know it's a little complicated. So it's all the people who went to the hospital for complications with chronic conditions like diabetes, hypertension, COPD, asthma, is a list of 10 chronic conditions. And then they were discharged. And that is the measure that we're seeing, and that can be used as an indicator of the quality of the access of outpatient high quality care. If you are not taking care of your diabetes, you are going to develop complications, and potentially you are going to end up in the hospital. And that hospitalization shouldn't happen if your diabetes is well managed through outpatient care. As you can see, this measure is going down, and in this case, lower rates are better. And from 2013 to 2019, the rate of potentially preventable hospital visits decreased. The next measure that we included for hospital utilization is the 30-day all-cause hospital readmissions. That means that any patient who had an inpatient visit in a hospital for any cause was discharged and then went back to the hospital within a 30-day period. That measure, a high rate of readmissions is tightly correlated with higher mortality, but also with higher costs. And that without mentioning the suffering and the disruption in life and families that that causes for everybody. As you can see, that measure has also trended down for the state of Colorado from 2013 to 2019. So in both cases, good news. And we're going to talk a little more about that particular measure later. Next one, please. Another new measure that we are very excited to share now, and it is related to mental health treatment or appropriate treatment. And as Doc mentioned, the state of Colorado has improved significantly in the treatment and addressing mental health conditions. The new measure, the title is very descriptive, follow up after somebody shows up in the emergency department used for mental health reasons. In this case, higher rates are better. And it has two indicators, that the follow-up happened within 7 days or that the follow-up happened within 30 days. Of course, the evidence suggests that the shorter time is always better, because if you get an appointment that is farther in the time, of course, it's much less likely that you are actually going to adhere to your appointment. So shorter time is also better, because it is more likely that you are going to adhere to the treatment, that you're actually going to show up, and it is also related with improved functioning overall. So we are also trending well. Higher is better, and that's the good news. Next one, please. And of course, I have to talk about cost, because as Doug also mentioned, that is an issue in the state of Colorado. Costs continue to rise. That's a reality. These are the costs per person per year for everything. So if we look at on the left side, you can see that the cost in the time period that we're studying from 2013 to 2019 increased 32% for everybody. And then when we break that by service category, inpatient, so that is all the charges that facilities like hospitals, hospices, and all the places where people spend at least one night are included here, also increased, but not too much during this time period. Professional charges, which are all the services provided by a physician or any other healthcare provider, whether in an inpatient or an outpatient facility, also increased 32%. Outpatient facility charges, that includes like all the ER visit outpatient facilities or other facilities like home health or rehabilitation, or if you go to an on-campus hospital visit that is not inpatient, that would be included there. And even FQHCs and rural health centers are counted as outpatient facilities, and that also increased. And of course, the pharmacy, which is all the prescriptions that were filled. As you can tell, the cost increased substantially. Actually, that's the one area where the costs increased the most within this time period. And just on the right, as if you remember, Joanna mentioned that we have the costs presented, what the plan paid, and also what the patient pays. What the patient pays is what is considered the out-of-pocket costs. We are not talking premiums, but we're talking about coinsurance and copays that happen also that the patient has to pay. And those costs also increase at least 13% in the time period. Next one, please. So in the last slide, we saw the increased cost overall. And here we're going to see the increasing cost by payer type. So if you look at the graph, of course, the highest graph, the line that is at the top is Medicare fee-for-service, and then the one that follows is Medicare Advantage. So those are the two payer types that have the higher costs, and that makes sense because they serve a population that is 65 and older that has higher healthcare needs. But then you see commercial and Medicaid at the bottom. But you see that overall, in all the payer types had increases in cost, but the one with the largest increase in the time period studies is Medicare Advantage and commercial payers. And Medicaid and Medicare fee-for-service are the two programs with the most modest increases in cost in the 8 years included. Next one, please. And because Doug was also talking about, well, and what is within Colorado? We know that Colorado is doing already not so great in terms of cost. But if we look inside Colorado, we then also see that costs vary widely if we look at counties. And we have a county that has almost $14,000 per person per year when we consider all the costs paid by both the plan and the patient. And that is almost double almost double than the average for the state as a whole, and 3 times than the county that has the lowest cost. And this is important. This is important for those who are in the counties working to improve and decrease costs for everyone, and yes, to explore what is driving the higher costs in specific localities and exploring how the healthcare system works in that specific site. And next one, please. One more about pharmacy, since pharmacy was just so extremely important in raising as a driver of the rising costs in Colorado. As you can see, this is again, Medicare fee-for-service and Medicare Advantage are the payer types with the higher costs in pharmacy, which makes sense given that it is the older population who uses more prescriptions. But if you compare the cost in 2013 against the cost in 2019, you can see that the highest increase was for the Medicare Advantage population and for commercial payers, particularly. Next one, please. And just to talk even more about cost, I would like you to just pay attention first to the purple bar. This graph describes the percentage increase between 2013 and 2019 by payer type and by service category. And the total is all the services together and for each payer. And you can see clearly that the one payer type that has the highest percentage increase again is Medicare Advantage. Then if you look at the gray bar, it is pharmacy in Medicare Advantage, the one with the highest increase percentage between 2013 and 2019, followed by commercial. It is noticeable if you look now at the green bar, and that is inpatient costs. Inpatient costs actually didn't increase as much, and for payers like Medicaid, they even decreased. Next one, please. Okay, so now we're gonna change gears a little bit, and we're gonna talk about the 30-day hospital readmission measure that we talked about. And as Doug mentioned also, Colorado was doing well in this measure. And when we look at the rate of 30-day hospital readmissions by payer type over the time period, we see that for most of the payers, this measure has decreased, with the exception of Medicare Advantage. And Medicaid has increased. Commercial was never too high, but also decreased. Sorry. So this is good news. So this looks like good news, but we can move to the next one. And this looks at 30-day hospital readmission across the counties in Colorado. And if you see, well, there is still a lot of room for improvement in some counties. The Colorado as a whole has a good, compared to other states, 30-day readmission rate. But if you look at other counties, you see that there are counties that are not doing very well. Hospital readmission, as I said before, is a measure that correlates highly with mortality and with higher costs, but also with a lot of disruption for families and people. And it can be improved not only with access to high quality of care and plans, discharge plans in hospitals, but also with care coordination and access to social services that are going to support patient management once the patients are discharged from the hospital. And there are many programs now that are working exactly on that, making sure that patients have everything they need, not only in terms of medication and instructions, but they also have a safe place to go to recover. They have food to access, and they have some type of social support so they can actually recover and don't go back to the hospitals. And those are things that have to be worked, of course, in the health systems, but also in the communities, making sure that we have local communities that can provide the social services that people are going to need to be able to recover and get better. And this is all I have to share for now, because of course we're going to have many other things to share. And just to reiterate, like Joanna said, we welcome questions right now or anytime. Please feel free to contact us. We really like to hear from you and to hear what is useful, what would be better to have in the future, and how you would like us to present this information to you. Thank you.
Thank you, Maria. And thank you, Juana and Doug as well. A reminder to everybody, please do let us know if you have any questions or comments by using the chat button. We'll go ahead and take some Q&A here, and I'll give you guys a minute to do that. As Maria mentioned, we're not just asking for questions too. If you have feedback, if you see something and you go, I don't know about that, I would have done it a different way. We are always looking to make these reports and the information that we provide better. So that's something that we strive to do every single time that we release something. We listen, and we want to make sure that it's useful to those in Colorado and beyond. And while we're waiting for some questions to come in, Doug, I wanted to put you on the spot a little bit, although I did prep you. Doug had a chance to actually use this data. Since he got the sneak peek, he was able to get access to the downloadable data for his county and shared it with some physicians. And I just wanted to ask you how that went, what the feedback was, and how people are thinking about using this in your county. Oh, I'm not hearing you, even though it looks like
double muted.
Oh, there you are.
We found it incredibly valuable to use the dashboard for our county, La Plata, in Southwest Colorado. And not only because of the breadth of the indicators, but the ability to drill down. And we looked at trends over time. And then we also looked at, for example, the different payers by cost. And we saw that even though we looked pretty good overall, that was masking the fact that we had a sharp increase in commercial costs in our county, much greater than the state average. And when we looked at utilization, that didn't seem to be what was driving it. We could drill down and see that it was really being driven by outpatient and pharmacy. So that gave us some indicators of what's really the situation in our community that's different than others, perhaps. And also some surprises on quality. We were doing much better on follow-up for mental health visits than providers would have guessed, but they were surprised that we weren't doing as well on preventive care. So there was some head scratching, but also some thoughts about what we could do about this with maybe patient education. If deductibles are getting in the way of preventive care, we need to help patients to realize these are free services. They don't have to have that subject to their deductible. I hope other counties will be able to have similar experiences.
Thank you for sharing that. Yeah, it's exciting to us to hear how people are using it. And I think it is really interesting to, as Maria was noting, even just looking across Colorado on the areas where we look like we're doing pretty good in your individual county or area, you may not be doing that great compared to others. So I think it's really interesting to keep going down and deeper into the data. I don't think we have any questions in the chat coming in just yet. I did want to ask Doug if you've had, it's just depressing to see the death and despair data for Colorado, and obviously suicides. It's been an issue, and mental health has been an issue, and there are lots of things going on in Colorado. I think we're doing a good job at addressing it at the state level with some policy and work groups and things like that. But I'm just curious if you at the Commonwealth Fund have you seen any best practices in states that are doing a lot better than Colorado? Anything that you can share with us?
Yeah, I think the hub model that was put in place in Vermont is really promising, where you're trying to empower primary care physicians to work with specialists. It's kind of like the ECHO model in a way, to have the capabilities in primary care for mild to moderate, and then for more severe cases, being able to refer patients. And here I'm talking about substance abuse in particular, for help. And of course, with collaborative care for mental health issues is shown to be very effective, and it's growing, getting wider adoption. So I think telehealth is providing some new, unique opportunities, and it will be exciting to see what we can learn from what had happened during the pandemic. We're all very concerned that we may have lost progress and during that time, even though a lot of effort has gone into it pre-pandemic. We need to reignite those efforts now that we're coming out.
Thank you for that. And then lastly, I wondered, Maria, if you could just share with folks, I know a focus for Civic over the last year has been trying to capture health equity information to overlay, because that's a gap in our ability to right now provide information, again, at another level. Even though you're looking at all commercial payers, that doesn't say what a particular group might be experiencing on the health equity stage. So can you just share with us just real quick what we've done in the last year to kind of advance our ability to report on that and what's coming?
Sure. I'm happy to. And we have here also Joanna, who worked so closely on that, on making that happen for us. And what we did was to geocode the members represented in the Colorado APCD. And geocode means to give a geographic location identifier, which will allow us to link the members to information at the geography level that is provided by many public sources. The most important would be the census, which has the American Community Survey that provides information about poverty, about income, about people who don't speak English very well, or representation of different race ethnicities in specific locations. Of course, this is not the same that having race, ethnicity, and income and education for each individual in the APCD, but it is a good indicator that tells us that people who come from certain areas usually share those socioeconomic indicators. And there is a lot of evidence that shows that having some geographic indicators actually correlates closely with population health outcomes and with some healthcare utilization and healthcare quality patterns. So we will have this information available, and we can't wait to join and to display the measures that we have seen today, adding these geographically aggregated indicators to know more about communities and to understand much better what is impacting those indicators that we saw, like cost or hospital readmission, that vary so widely in different places. We can know something about the healthcare system, but we need to know more about what are the characteristics of those counties or those even smaller areas than counties in terms of poverty and access to transportation and crowded housing and things like that can be useful to target and to have more targeted actions to improve. So that's No, thank
Yes,
you
more to come. We're
for bringing that
excited
up. More to come.
yeah,
Yes.
we're excited to be able to overlay some of that information. And thank you again to Awana for all the work that you did to get us to that place with the data warehouse infrastructure. So there was a lot of work that went into it and a lot of things we learned. So if you have questions, reach out to Awana because she's the guru on that.
And the team.
Yeah, yeah, it does take a village, doesn't it? So, and I don't think I ever really said when the community dashboard is scheduled to go live, but we are aiming to push it out in our newsletter at the end of this month. So stay tuned. Hopefully you are connected to us. If you are not, if you go onto our website, you can sign up for our emails. It's at the bottom of and all over our website. Please join our mailing list if you're not already. Reminder that the recording will be posted on our website under the events resources page. And our next webinar is going to be in November. It's the 18th from 12 to 1. We're looking at Center of Excellence on Health System Performance and getting hopefully some presenters lined up from the National Bureau of Economic Research as well as RAND. Stay tuned for exact presentation information and speaker information. But we're very excited that all of you joined us today. Thank you, Doug, for all the resources that you put into the chat. And thank you to Awana and Doug and Maria for being incredible presenters today on this important topic. We look forward to seeing many of you in November. Thanks and have a great rest of your day.
Thanks. Bye-bye.
Thank you, you too.
Thank you.